Welcome to Mental Health Mini number 1. In Mental Health Minis, we will be covering concepts related to mental health nursing in a brief and shortened amount of time compared to a typical lecture. This first Mental Health Mini is focusing on the history of mental health care in mental health settings. Key terms when describing mental health care is mental health, mental illness or disorders, recovery, and wellness. Mental health is the emotional, psychological, and social well being of an individual. It affects our behaviors and actions, how we think, how we feel, and how we interact with others. It also drives how we cope with situations, how we learn, and how we grow and develop cognitively. A mental illness is a disturbance in our mental health when our mental health is not functioning as it should. These are conditions that can affect our mood, our thoughts, and our behaviors. When someone is diagnosed with a mental illness, we initiate treatment to help them get to a place of recovery. Recovery is optimizing health with minimal treatment. And then wellness is the state of being in good or balanced health. When approaching mental health care, we look at the 8 dimensions of wellness to try and identify the key areas of an individual's life that we can implement interventions to help them reach a place of recovery and wellness. The 8 dimensions of wellness include emotional health, physical health, social health, occupational health, financial health, environmental health, spiritual health, and intellectual health. A couple of key points about some of these dimensions. Intellectual health does not necessarily mean that the individual is growing in intelligence or that they are of high intelligence. Intellectual health means, are we stimulating that individual's mind so that they can grow and develop? Are they able to use creativity? For environmental health, we want to have an aesthetically pleasing environment and a place where we enjoy being, but we also want to focus on the health and safety of that environment as well. Occupationally doesn't necessarily mean that the individual has to have a job, but that they have to feel productive to society. The history of mental illness kind of ebbs and flows. The pre-classical period, which is prior to 400 BCE, is a time when they believed that mental illness was caused by evil spirits, loss of the soul, sinning against a god, or breaking a taboo. At that time, they would initiate treatments to try and get that individual's soul back, or to try and fight any evil spirits, or to atone for the taboo or sin that they caused. This led to a lot of barbaric treatments that are no longer used today. Then in the classical era, at 400 BCE, there started to become talk that mental illness was caused by the 4 humors, which was blood, black bile, yellow bile, and phlegm. And in order to correct any imbalances in the 4 humors, treatments such as bloodletting or purging were initiated to try and treat that mental illness. After this, we reach the Middle Ages, and we see a little bit of a regression where mental illness is again presumed to be related to the supernatural instead of a possible physical cause. At this time, they believe that witchcraft and supernatural activity caused mental illness, and therefore we saw an increase in torture devices, in isolation, in exorcisms, and in things like that. Then in the 1700s, we started the asylum system. Prior to the asylum system, individuals with mental illness were cared for in the home and community, but at the start of the asylum system, we were able to treat individuals in a hospital-based setting. The issue with asylums is while they were intended or built with good intent, they often became overpopulated, at times 1 provider to 300 patients, and this led to neglect, it led to abuse, and it led to very poor outcomes and poor living conditions for the individuals that were in asylums. So in the 1800s, people started to notice this and said, hey, let's improve asylums. They started to improve the humanity and the function of asylums, as well as the physical structure to try and combat some of that abuse and neglect that was happening. The 1800s is also when the start of psychiatric nursing began, with the first psychiatric nursing program being developed in Massachusetts. In the 1900s, we transitioned from asylums to state hospitals. This was a revolutionary progress in the treatment of mental health care because it implemented the Kirkbride system, which is a system where we focused on improving the milieu as well as improving the conditions that the patients were living in and the treatments that they were receiving. It focused on productivity and it focused on treating patients that truly needed hospitalization rather than individuals that were hospitalized because they upset their husband or because somebody didn't like them, as we saw prior to this time. During the 1900s, in particular, the mid-century, we start seeing psychiatric education being implemented into nursing curriculum. We also saw the introduction of new medications, in particular antipsychotics, which really led to an improvement in the treatment and experiences of people with mental illness. We also saw a shift from patient-focused to nurse-patient relationship-focused care for mentally ill individuals. And now into modern day, we treat individuals with mental illness in multiple different settings with multiple treatment options. We have significantly improved the care and the perception of individuals with mental illness. However, it is still something that's quite stigmatized. We've also increased our focus on physical causes of mental illness as well as the emotional causes. And we also have improved our focus on prevention of mental illness or prevention of relapse of symptoms. There's quite a few different settings that we can treat individuals with a mental illness nowadays within the healthcare system. First and foremost, we see people with mental illness in every healthcare setting. So whether you're a psych nurse or not, you're a psych nurse because you're going to have patients that have mental illness in an OB setting, in a med-surg setting, in an ICU setting, in the ER. No matter what type of nursing you go into, you're going to have to care for people that are experiencing either a mental illness or symptoms of mental illness and emotional distress. When we're looking at the mental health care settings, we follow something called least restrictive treatment. And what that means is that we start focusing on what's going to be least restrictive for that individual and then increasing the level of care based on those patients' needs. So first and foremost, we're going to start with self-management. If someone's experiencing depression or anxiety, we're going to try and figure out the trigger for that and see if we can eliminate the trigger or help them to build improved nutrition, improved exercise, improved sleep, improved organization, and see if that helps to treat the symptoms. If it doesn't, we can refer them to counseling and therapy. This is often done by a social worker or a psychiatrist or a psychiatric nurse practitioner. If that is ineffective, we can progress them to outpatient treatment, where they may see a psychiatrist that prescribes them medications and other treatment modalities that they can do outside of the hospital. If someone needs a little bit more treatment than an outpatient treatment, we can refer them to what's called a partial program. A partial program is going to be similar to the treatment that you're going to receive in inpatient therapy, in the sense that you see a psychiatrist every day, you have medication management, you see a social worker, and you attend different types of groups to help manage your psychiatric symptoms, but you get to go home at the end of the day. So at this point, you're not a threat to yourself or anyone else, and you're able to care for yourself well enough that you're able to return home at the end of the day. The inpatient facility, on the other hand, is similar to the partial program where you have the same structure of treatment, but the individual is not able to keep themselves or others safe, or their severity of their illness is so intense that they're not able to properly care for themselves, and therefore they have to stay at the hospital. Inpatient facilities have are locked units, so the individual is not able to leave once they are admitted. You could be admitted 3 different ways, either voluntarily, meaning that the patient comes to the hospital and says, I believe that I need treatment, and so they sign themselves in. It can be involuntarily, where somebody else believes that the patient needs treatment, so they file a petition form that explains why the patient may need treatment, and they do have to reach certain criteria. Then the patient's brought to the hospital, they're cleared for any medical causes, and they're seen by 2 different psychiatrists, one within 24 hours and then another one within 48 hours, to confirm that the reason for admission is accurate and that they also believe that that patient needs treatment. Then we have residential treatment. Residential treatment is a more long-term setting, and it can be for pediatrics or adults. And by long term, I mean anywhere from 3 months to 3 years. These individuals live at the facility where they receive treatment, um, and they are able to come and go, but under supervision. Then we have group homes and adult foster care. And this is kind of what it sounds like. It's when someone takes in someone with mental illness that's unable to live on their own, that does not have family members or friends that can support them. Um, at some group homes, they may receive treatments and have groups and have access to social workers. In other settings, they do not. And then lastly, we have forensic centers. Forensic centers focus on two different purposes. One, the purpose of caring for an individual that's on trial for a crime, and two, caring for individuals who have been convicted of a crime. And when I say that, what I mean is if someone commits a crime, but there's reason to believe that the crime was due to mental illness rather than conscious intent, then they have to stand trial. If they are still incompetent, which means they're not able to understand the situation, they're not able to process the benefits and risks of their actions, and they're not able to communicate effectively, then they're not able to stand trial. So the forensic center gives them 6 months to receive treatment to see if they can get them to a place of competence to stand trial. If they don't within those 6 months, then their treatment is extended for another 6 months until they can attend trial. The second part is if they are deemed not guilty by reason of insanity, so they've stood trial or they've been determined that they're unable to stand trial due to long-term mental illness and that the crime was committed due to the mental illness and not to the individual itself, then they receive their sentence. The sentence would be the same as if they were not insane. However, instead of fulfilling that sentence in the prison, they fulfill it in a forensic center. And that is our psychiatric mini for mental health care history and settings.